Wonderful. Okay, well, hello, everybody. It's my pleasure to moderate today's session. I'll start with our land acknowledgement. So first, my name is Michael Khoury, and I'm an assistant professor and pediatric cardiologist with the heart failure and transplant team here at the Stollery Children's Hospital. The University of Alberta acknowledges that we're located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada whose presence continues to enrich our vibrant community. I'd like to also thank Paladin for their support of the ATI seminar series. So without further ado, I'd like to introduce our speakers, and it's a particular joy for me today because these speakers are former teachers of mine from the Hospital for Sick Children. So Dr. Briseida Mema is a staff physician in the Department of Critical Care Medicine at Sick Kids Hospital and an associate professor of pediatrics at the University of Toronto. She's the program director for the Pediatric Critical Care Medicine Training Program at U of T and has received several awards for teaching excellence as a trainee and a faculty, and I can certainly attest to that. She is a clinician educator, and her interests include skills teaching through simulation, transfer of learning from simulation to clinical contexts, and assessment. She was the recipient of the University of Toronto Medical Humanities Education Grant in 2019, 2020, and 2021, and she runs a medical humanities curriculum for trainees and faculty in intensive care to support the lifelong journey of the professional identity and transformation. Dr. Haifa Mtaweh is a staff physician in the Department of Critical Care Medicine at the Hospital for Sick Children and assistant professor of pediatrics at U of T. Her research focuses on improving outcomes of pediatric critical illness and holds the role of hospital donation physician at Sick Kids. She focuses on improving access to donation opportunities and ensuring provincial guidelines on organ donation are implemented locally. She collaborates with Briseida on educational aspects and opportunities as related to donation. So their talk today will be entitled The Gift of Life, Interprofessional Organ Donation Curriculums in Pediatric Critical Care.
Thank you, Michael, for your generous introduction. So I'm Haifa Mtaweh. This is Briseida Mema, so people put a name to the face. We'll go through, thank you for the invite from Alberta Transplant Institute to present about this. This came after our publication in ATS Scholar. I'll start with disclosures. As Michael said, I'm the hospital donation physician at Sick Kids, and Briseida does not have any conflict of interest to disclose. We'll go through a summary of the interprofessional curriculum that we have here in pediatric critical care medicine, the implementation of the curriculum in the unit, and discuss the processes that assure organ donation discussions are part of the end-of-life care that we provide in our critical care medicine department. So historical context is always nice to remember and know about donation. So the first mentions of organ donation were from Bien Ku in 300 BC. Basically reports about two men, one with a willpower deficiency and one with a mental power deficiency, where a heart transplant basically was exchanged, and both men woke up from that procedure like new different men, as good as new. And then there's the Cosmas and Damien. Although the title of their transplant is called The Miracle of the Black Leg, and it's basically, it depicts a man who was a soldier whose leg was injured during the war and had basically a limb transplanted, and they were declared or made saints in the 11th century. And then time moves forward and medicine advances, and then Jaboulet and Carroll are the two scientists or physicians who discuss vascular or start working on vascular anastomosis. And it's thought that Jaboulet is one of the first physicians who performed a kidney transplant in humans, and it was using a pig donor, and of course that did not succeed. Multiple other attempts were done with deceased organs and relatives of patients, and all were met with failure due to thought to be the vascular anastomosis that was refined, and then rejection was one of the major hurdles. And then comes 1954, the Murray and the Herrick twin brothers story that led to Murray winning the Nobel Prize in the 1950s, and it's a kidney transplant. And liver transplants took a bit longer due to the complexity of their vascular anastomoses, but it was done in the 1960s by Starzl, and the first transplant was not successful, and then the second one was perfected, and the liver was transplanted successfully in a patient. That brings us to pediatric donations. And this is our area of focus, and it's faced with multiple hurdles and difficulties. As you know, pediatric donation is lower in numbers than in children than in adults. Due to multiple reasons, some of these can be modifiable and none are not modifiable. First, death is a rare occurrence in children. There is a big range of size and the huge donor and recipient size mismatch. There's lots of missed opportunities in pediatrics to approach for donation, and that's variable depending on where we practice medicine, whether which province, which country, as you might expect. And then there's misconceptions, usually by physicians and practicing physicians and bedside staff, about organ donor eligibility. And as you can see, some of these we can change and others that we cannot. At SickKids, we've developed kind of a cohesive approach that centers the patient and their right to quality of end-of-life care. And we view donation as one of the key aspects to provide that. And there's three interrelated partners in that process. These are the healthcare professionals, the organ procurement organization in Ontario, which is TGLN, Trillium Gift of Life Network, and then of course the family with their wishes. So our focus is on healthcare professional identifying patients and initiating as early as possible within reasonable timeframes a call to organ procurement organization where consults, discussions can happen away from the bedside to allow the engagement of the family into the decision making of understanding what their wishes are for their child, the education about the process, what it entails, what it means for them as a family and their child, to lead towards organ donation or not, so depending on their consent. And while all of that is going, there is a focus on the medical management of the potential donor and and the optimization of that. Of course, it's as organ donation remains a rare occurrence in pediatrics, education and the maintenance of that education and skill set remains a cornerstone of that. That brings us to the literature gaps that we identified and tried to tackle. Basically, a survey of intensive care trainees revealed that there is discomfort and lack of knowledge regarding organ donation guidelines and processes. This was a non-Canadian survey, and similarly, a needs assessment of ICU nurses identified that there is a need for further education about how the process occurs, whether locally, in the area of their practice, and on how to manage potential donors prior to their family's consent, and then, of course, after the families have provided consent. And then in a Canadian survey of ICU and emergency medicine physicians and nurses, they all revealed that there was different practitioners, some senior, some junior practitioners, and throughout the different domains that we practice in, everyone identified the need for education on the process of donor referral, how to communicate with families, the donor management itself, and donation after cardiocirculatory death, which was identified as one of the needs. And this led us to the objective of our creating a curriculum, and I'll pass on to Briseida.
So this is really a curriculum roadmap, right? Like just like everything we do in medicine, we kind of have a plan about what we want to do, and then we implement that plan. Okay. So in terms of how to go about it, because as Michael introduced me, I'm an educator, Haifa is a scientist, and that's where I came in. I also had done the organ donation physicians for a number of years before took over the program director, and Haifa took over the organ donation program. And so we both have had some interest of building a curricula that was founded on educational theory. So the first one we chose was Kern's curriculum framework is a very good framework because it's quite like, straightforward. And Kern was an educationalist from Johns Hopkins, and he based that on, societal gap and system theory, etc. So you can see there the little circle and many arrows, because sometimes it's not a straightforward circle and you can go from one to another. But the first one is, the problem identification and general needs assessment. Like, is this a healthcare problem? And what is the current approach? And what is the ideal approach? And Haifa just spoke about that how there is a lot of data that there is a problem. And here we see, organ donation or approaching the family as high quality end of life care. And then is the needs assessment of your targeted learners. Who are your learners? And then, what are your goals and objectives of your curriculum? How are you going to address it with educational strategies? How you implement it? And then how do you evaluate the individual and the program as a whole? So this was the first framework for an educational perspective that we chose. Now, we're both intensivists, and Michael is a cardiologist, and we love physiology. So sometimes when we go at the patient bedside, we want to know, well, what is the physiology of the patient, what to do about it? And educational theories are, in a way, the physiology of education. And before embarking on a curriculum, you have to know, well, how am I going to do this? So the next one was that this curriculum was not simply for our learners, meaning the fellows or the trainees. This was for almost everyone in the unit. It was the nurses, the RTs, we needed the organ donation, coordinators, physicians, etc. So the next framework we chose with Canadian Interprofessional Health Collaborative Framework. First, because it's Canadian, and second, because it's actually a very good framework in terms of when you build interprofessional program, what are things that you have to keep in mind. And while the goal is interprofessional collaboration, a partnership to provide like excellent care, there are a few things that need to be kept in mind, like role clarification. What does everyone do? How is the team going to function at the whole when there are many leaders for different professions? How are we going to have a collaborative leadership? And like everything that we do when it's interprofessional, there is some conflict and conflict resolution. So all of these two frameworks were kept in mind when we started building this curriculum. And so going back to Kern's framework and Kern's cycle, Haifa spoke about problem identification and general needs assessment, and the needs of assessment of our targeted learners who was pretty much everyone in ICU who provides end-of-life care. And that takes us to goals and objectives. I'm going to, not to make this exhausted, but we're going to show some of the tables that we involved in our publication. One was we thought, okay, what is good to target with lectures? And how are we going to do that? Where is it going to be applied when we train nurses, when we train RT, when we train our physicians? And so there are things that they can very easily be targeted with lecture. And then the next one is, where do we actually use simulation for? Because simulation is quite expensive and it's time commitment. And so that is the first decision we make. Okay, what is going to be lecture? What is going to be in simulation, and what exactly? And then what is going to be in supervised clinical practices, and how can we make that? Can we make those clinical experiences? How can we maximize the learning from those? So once we had those goals and objectives, and then is what type of educational strategies are we going to use? And I spoke a little bit about lecture, simulation, and clinical experiences. And then you go to something that is called blueprint in medicine, and is in education is just content, and how you organize the content, that is the blueprint. So first, what content do you want to include or exclude? Because there's so much that you can include. what competencies or challenges for the participant do you want to have? And then what are some characteristics of the cases that are you going to build? And then you compile the set of cases and challenges. And of course, feasibility is pretty big because each programs have their own context. So in terms of whenever we talk about sample of educational objectives or cases in education, it's very good to think because a lot of people are used to research, right? How do you sample for research? And it's a little bit like research in a way because you cannot observe everything and you cannot going to do a sample of material and miss some other things that is important. So things to think that we thought about is how do we gather what is very frequent that we want people to know, that we don't want people to miss it? What is urgent and what is important? And when you think of organ donation, it fits all of this. So you can have a very nice blueprint with your goals and objectives and your educational strategy. And then when I sometimes English being my second language use expressions wrong, but where rubber hit the mat, you find that, I have all this plan and how is this going to work out really? So we did look at what exactly was going on in the unit in terms of educational activities where we could put the organ donation curriculum. So there was a lot of lectures in Nursing Education Day, a residence academic half-a-day curriculum, and the respiratory therapy education. So all the lectures and the objectives was put in there. And then in team-based simulation, we had, some of us as physicians who had interest in organ donation, Haifa, myself, with another colleague, Andrew Helmers, with ethics background, we met and said, what would be and Diana, of course, Diana Lee, our Trillium Gift of Life coordinator, we're like, what are things that will be good to target with simulation? And that's what we did for team-based simulation when the RT, the RN, the physicians worked together. And then we looked at what clinical exposures do we have to maximize when they happen, because we're not going to have an NDD, just for the sake of NDD. And so how to maximize when those things happen. And then the discussions were case debriefs, and Diana, who is our coordinator, is instrumental in holding those with Haifa, the interprofessional care rounds, and then mortality reviews. So looking at what is existing in your education program and how do you insert the curriculum that you have thought about. So going back to Kearns, the last thing would be the program evaluation. And so I'm going to speak a little bit about underpinning theories here, because program evaluation can be of your program or of the individual. And so there are many evaluation approaches. Some focus simply on outcomes. Does it work? And then you have experimental and quasi-experimental models, Kirkpatrick model, do you know what to do? Are you doing what you should do, etc.? And then focus on context or processes is one of them, very famous, is how does it work? Is the SIP model. What is your context? What is your input, processing, and product? And then one that is very liked in medical education literature, and here QI and program evaluation interlap, of course, and implementation science, is the theory. What is your planned theory about your program? Why will it work? What did you have planned in process and outcome? And was it emergent that you didn't think about, and how to value that as well? But considering we had just started this curriculum, we thought, let's start looking at the learners with something that is a bit more simple. So when we looked at the individual learner evaluation, we decided to do something called retrospective pre and post. So it's still a self-assessment, but instead of collecting data at the beginning and at the end of the program, the retrospective pre-post approach collect data only at the end by asking participants to self-assess what they knew before they engaged in this curriculum, and what we knew before and what they knew after. And so now I'm going to let Haifa go over the individual evaluations as well as the program evaluations.
So we thought the best place to incorporate the retrospective pre and post is in the simulation discussions that we have with our different participants. So Briseida has put with the team a lot of effort to include healthcare professionals from different domains. So we usually include about 130 participants with 23 junior trainee physicians, try to equalize the number of professionals from different training backgrounds, 23 senior trainees, 22 nurses, and 25 respiratory therapists. And these were the scenarios that these healthcare professionals go through and evaluate themselves pre and post simulation. So we focus on breaking bad news, end of life in a pandemic, donation after cardiocirculatory death, procedures that would need to be performed in NDD, and then of course, neurologic determination of death. And these are reflective of their median scores before and after, just a quick snapshot of what they think they performed on a score of 100. And in each of those scenarios, the group data suggests that there was an improvement in the pre versus post simulation. If we look at, I just split some of the 4 of those scenarios into the involved groups. So the numbers that I reflected here is not the number that necessarily evaluates themselves towards the end. And these are different participants in different numbers of the scenarios. They're not all conducted at the same time. And you can see the different groups and what their pre-simulation, post-simulation data looks like or suggests where the potentially maximal benefit was. There's trends in certain subtopics that people find more benefit in those discussions. Our internal process for the program, so that's evaluation of the trainees and the learners and the individuals who make our healthcare team, and then there's evaluation of the overall process of organ donation at Sick Kids that we thought would be valuable to share with the group. So we have our own local process evaluation, like Briseida suggested, our case debriefs that include usually everyone involved in the donation process. And it includes individuals across the trajectory from ICU to the ORs to the ward if individuals were involved in around the end of a life of a patient that led to organ donation. We also have our mandatory reporting in Ontario that the hospital has to report to Trillium Gift of Life Network, and these are publicly available data. I just put 3 of the ones that are reported and publicly available. So the notification rate, conversion rate, and the eligible approach rate. And the definitions are here for someone who's interested. So these are for every hospital in Ontario, these are publicly reported. And we are provided with a quarterly report of how compliant we are with each of the cutoffs for these rates. And then in these quarterly reviews that we hold, so there is an organ donation committee where we discuss cases, the number of referrals that have been obtained, the number that it's declined, if there is any reason for lack of approach that's clarified, if there's any system issues that would improve our ability to provide the family with the opportunity to consent or not consent to the organ donation itself, that we can address. So these are discussed in those meetings to try to identify those barriers after the debriefs are done at the bedside. And then an additional component of this quality improvement is the feedback to the bedside care providers to provide kind of a snapshot of the numbers and how many lives have been saved by the act of donation by our generous families. Where does this lead us? So the next steps are a focus on 2 components: quantitative data generation. So how did this education curriculum and its establishment and then implementation in the at Sick Kids change our publicly reported data and our other rates of interest in regards to organ donation, and then a review of the donor management at the bedside. And then qualitative aspects are the experiences of the families in relation to donation process. And I know you guys are hosting Amy Sarti next week, so she has a lot of experience with this too. And then the experiences of healthcare providers in relation to donations, specifically from healthcare providers from different domains. So in conclusion, pediatric donation, it is a high stakes and low frequency. We've reviewed the interprofessional curriculum using Kern's framework and the Canadian Interprofessional Health Collaborative Framework. I think the program is adaptable to different contexts, but each context will have its own needs that requires to be assessed first prior to the implementation of any education. And then the success, I think, is related to three major factors. First, the culture of the institution that would support the interprofessional education and collaboration. The presence of a designated hospital coordinator from TGLN, who's tasked with some of that local education and awareness, and of course, ensuring that the process follows the standard that we've set, and then a sound educational design. Thank you. Happy to take questions.
And I'm back after a broken chair.
Sorry about that.
with the new chair.
Michael, should I stop sharing? How would you?
Whatever you prefer. I think either way. That was a really wonderful and insightful talk. Thanks very much, Haifa and Briseida. Really interesting. I'll stop and see if anybody has any questions. I have a couple, but just in case, in the interest of time, I want to see if anybody has any questions. In the meantime, just feel free to put your questions in the chat box, and I'll be monitoring that, or just put your hand up and we can answer that way. That figure towards the end that you showed with respect to the number of referrals, the number of families that were approached, and the numbers that consented, it was pretty eye-opening to me to see, of 95 referrals, 3 donations came out of it. Now, of course, if you're referring everybody, then there will be people that are not appropriate donors. So then of the 16 that were approached, 3 donations came. And then of the ones that weren't approached, it seemed that it said some of them would not have accepted. And so I was wondering whether in your experience or whether if these sort of numbers are similar in other centers, and is this sort of what one would expect in terms of numbers of referrals and number of actual donations that occur?
So it's hard to compare the centers within Ontario, right? The number of, it's dependent on the patient volume per center, and I can't speak to that because this data I'm sharing kind of data that comes back to sick kids. I don't have access to the number of referrals, but I know we do have in our program, it is a mandatory referral. So it's initiated by any one of the healthcare team as soon as an end of life discussion is started to notify about a potential death. It doesn't mean that every notification leads to an approach to the family. It depends on the circumstances. Does this reflect? So I would say on an average, granted, this was right after we started getting back to post-COVID kind of activity at our ICU. We have about 5 to 6 donations, and in exceptional years, we've had a bit more towards 8. So in pediatrics in general, this is very similar to what other centers have. Larger volume centers. I don't want to use the term bigger. The larger volume of patients. There's a lot of factors that play into the rationale for not asking to be approached. We don't face that a lot in the families who are admitted to the ICU. Usually the coordinator introduces herself to one of the care team members, and she or he are introduced as part of the end of life care, and they talk about organ donation. And then rarely we've had instances personally that we reflect on where families know about organ donation, that it's part of the process, and they will meet a coordinator, and that's when they say that they don't want to do that. And we respect those opinions. I wouldn't say it's a frequent occurrence based on my clinical experience and based on the review of numbers across the years. Briseida, you have that perspective too.
Yeah, so we have, as you said, Michael, we have mandatory reporting. So at the moment that you have approached the family about withdrawal life-sustaining therapy, no matter who the patient is, and they have agreed to it, right? We call Trillium Gift of Life, and a coordinator will come. Sometimes they review the case and they would say, it's a multi-organ system failure, etc. Those are the numbers that you see that they were not approached because there is not a potential. COVID as well is not a potential. And so when there is a potential, then the coordinator will come here, the NDD, they all will be called, and every withdrawal life-sustaining treatment where the family has agreed to go ahead with the withdrawal will be called. The Trillium coordinator will look where there is potential. They will come and approach, and then it's up to the family, of course. All we want to do is to give every family the opportunity to hear about donation. Sometimes, we all know that we're all human beings, and sometimes it's very hard because the family has had so much to deal with and so much information. So one thing that we also do with the coordinator is, because as a healthcare team, the physician and the nurse know best what state the family is in, and sometimes we can discuss with the coordinator about when is the right time to go. And so, because sometimes the family might be so tired that they say, I don't want to hear about anything anymore. I've been through so much, and they're not able to even hear the information and make an informed decision. That's where we as a team can help. Don't know if we answered your question, but I think the data, the data I think is similar to large volume centers.
Yeah, I would assume that it is, and I get the sense that this is the natural process. I think being on the other side, on the transplant side, we often don't get the same sort of insights about, how extensive a process is required for really what's required to undertake this. So no, absolutely. Switching gears a little bit. So the retrospective pre-post study design. So forgive my ignorance. But what is the rationale for using that? Like, what are the benefits of that approach versus assessing their knowledge at baseline and then assessing it after the intervention, so to speak?
Okay. So you're talking about, so we chose a self-assessment, right, tool rather than an objective tool. Not that I want to call it objective, because there are tools that have validity evidence there, like checklists or global rating scales that say, okay, how did this person do in this type of situation? Now, when it comes to team-based learning, right, those tools becomes very muddy, because who are you assessing? Are you assessing the whole team, or are you assessing an individual? And if you look at the education literature for team assessment, there's so many tools, and while they measure different things, they don't measure what people as a whole are able to take individually and as a whole are able to take away. And for that reason, we thought it might be best here to ask participants to self-assess themselves. And so many people do, what is your knowledge now? And then they put them through simulation, and what is your knowledge after? The retrospective pre-post does a more informed self-assessment. So you only self-assess yourself after you have gone through simulation and you have gone through the debrief about what you did or you didn't do. And so was chosen for that reason.
You don't know what you don't know, basically. So because you're exposing different level of trainees to those scenarios, and each will have different backgrounds, different experiences, different learning across their learning journey. So after they've learned what we want them to learn, how do they feel about their knowledge pre?
Yeah, that's sort of what I assumed, and that makes total sense. So you have to be able to reflect on it if you haven't given it much thought before, basically, is what it sounds like. That's wonderful. Laura, you just turned your camera on. I don't know if you had a question.
No, it's so interesting. And I just wonder whether, so congratulations. And I wonder, just, do you have any other thoughts? And maybe I missed it, I was a little bit late, on the most effective way perhaps to expand this more broadly, especially amongst different jurisdictions and so on?
That's a tricky question.
Yeah.
I think our intention to do the publication is, this is a roadmap. And this is a roadmap and a skeleton that works for us in our context, but is there now, and anyone is able to take that and adapt it to their own context and what is feasible for them, because a lot of people speak about standardization of everything. But in education, standardizing thing is not always a good thing, because each program has a very different context. And so sometimes you can have, like, this is a plan, and then you can take that plan and adapt it to your own context, because sometimes you might have lectures and simulation and case-based learning, and sometimes you might have 2 out of 3, or you might have 5 out of, 3 or 4 that we have. And you can look at that blueprint and say, I can do some adjustment here. Anyhow.
In critical care training, I can say, just to follow up on Briseida's point and how we implement it, Briseida does have a critical care training boot camp for fellows who are going through pediatric critical care medicine. And there's trainees who come from across the country, and we make sure we include at least one scenario that targets organ donation or end of life and withdrawal of life-sustaining therapy in one of those boot camps. These are very physician focused though. They don't include nurses, RTs. They might be included in the simulation itself to facilitate the discussion, but not targeted towards learning there. I think, like Briseida said, it's a great, our initial thought was this worked for us and it's easy to maintain. Easy between quotation marks, because it requires personnel effort, right? People who are still committed towards doing this, and can be achieved within existing education curricula by adapting that. We didn't think about forcing our ideas on what worked for us in other places, but we're open for discussions and collaborations. If there's interest, we're more than happy to discuss it.
I think one of the things about our context is that, Michael, now we have a lot of international fellows, and some are from countries that NDD does not exist or organ donation does not exist, but we're very dependent on our fellows. So initially at the beginning, this is all geared toward fellows who have never been exposed to that, knowing that this is what's happening in Canada, and we depend on you because you're practicing here for the next 1 to 2 years. When we take it to nursing, because it's a lot of resource, and then how are you gonna we targeted new nursing, and we have a role called clinical nurse support. And so those people don't have a patient, they go around and then just help people. And so we target that group and new nurses. We target new respiratory therapists and the respiratory therapists who are like leader in charge leader, because they would know about what's going on, and we want the new people to know. So you always have to make like decisions about where is the most bang for your bucks, because we don't have unlimited resources. None of us has.
But that's what's so, additionally interesting about it, is it allows you to be, well, nimble and flexible and really not playing to your audience, but, adapting to the different people for whom this would be really valuable information. It's so interesting what you say about the fellows going back to countries and other jurisdictions where there might not be NDD. And, have you had enough of them go back to those countries to have any feedback about, like, will they have impacts there on the organ donation systems in those various places? I mean, they're just coming back, junior people probably, but nonetheless, as they are there longer and longer, perhaps that can have an influence.
we don't know. What we do know is that a few of our fellows, international fellows, but not in countries where no infrastructure exists, because that's very hard for an individual to do, right? Like, you know, one of our Japanese fellows is not going to go to Japan and change. But in countries where the infrastructure exists, many of our fellows have gone back to their institution and said, I have some expertise now, and then taken the role that Haifa has, the hospital donation lead.
Mm-hmm.
That has happened because they keep in touch with us and ask us about like protocols and other things, or with different questions.
Yeah, we haven't done a formal, it's interesting. It would be interesting to look at qualitative data of how the processes have changed after our fellows have joined other programs, but we haven't done it in a formal way like we've done for internally, locally.
Huge opportunities, Really great, very interesting work.
Thank you for your question.
We love your plants.
Yes, I was going to say.
Thank you.
Yeah, Lori frequently wins the Zoom background.
Yeah.
Yeah. And then she moves the camera so we know it's not a wallpaper. It's real. Yeah. Okay, this has been wonderful. I want to see if anybody else has any questions from the group. Okay, if not, then I'd really like to thank the both of you for a wonderful talk, really insightful, and I certainly learned a lot. So, and it's also, of course, so nice to see you guys. So thank you again.
And Diana and Michael. Have a great one.
Take care, guys.
Bye.